Hi everyone, my name is Nina Maguire and I'm an infectious diseases clinical pharmacy specialist at Penn Presbyterian Medical Center. And today I will be discussing the use of nitazoxanide for COVID-19. Nitazoxanide was originally developed in 1975 as a veterinary antihelminthic. In 1984, its efficacy was noted against human tapeworms. As use of the agent became more and more common, researchers discovered its antiviral activity. And then in 2002, it was FDA approved for the use in select parasitic infections. Nitazoxanide is specifically FDA approved for diarrhea caused by Giardia or Cryptosporidium. Outside of the United States, it is commonly used as a broad-spectrum antiparasitic agent. Specifically in Latin America, Egypt, India, and Bangladesh, it's approved widely for treatment of infections caused by intestinal protozoa and helminths. And in Brazil, it's approved for the treatment of norovirus and rotavirus. Nitazoxanide's spectrum of activity extends beyond one taxonomic class. As previously discussed, it has extensive antiprotozoal and antihelminthic activity. Additionally, antibacterial properties have also been noted in vitro, and antiviral activity has been noted both in vitro as well as clinical studies, particularly with influenza as well as hepatitis B and C. Nitazoxanide's traditional mechanism of action includes the inhibition of pyruvate ferredoxin oxidoreductase, which is an enzyme that is essential for the metabolism of anaerobic bacteria as well as parasites. Nitazoxanide also has many structural components that contribute to its large spectrum of activity, as well as its anti-proliferative and antioxidant effects, which I will discuss as this presentation continues. Nitazoxanide is a prodrug that is metabolized into tizoxanide. Hong and colleagues discussed the use of nitazoxanide in various viruses and highlighted its in vitro activity against MERS. They found that nitazoxanide inhibited viral end protein expression and inhibited the production of inflammatory cytokines, such as interleukin-6, to result in reduced viral protein accumulation in cells. The in vitro findings against MERS was the impetus for evaluating nitazoxanide for use in COVID-19. Researchers found nitazoxanide could play a role in COVID-19 endosomal and non-endosomal cell entry. Nitazoxanide also has generally been found to have multiple effects which would be of benefit in COVID-19, such as inhibition of multiple inflammatory cytokines. In one in vivo study, there was a 90% reduction of interleukin-6 after a one-time dose of nitazoxanide in mice. Additionally, nitazoxanide has been found to modulate the unfolded protein response signaling to promote antioxidant response, as well as inhibition of DPI to prevent cell damage. Nitazoxanide is currently available as a 500 milligram tablet or an oral suspension at a concentration of 100 milligrams per 5 ml. The most common dosing scheme used in adults in the United States is a 500 milligram tablet every 12 hours for a duration of 3 days. From a pharmacokinetic perspective, nitazoxanide's absorption is variable dependent on which formulation is chosen. The suspension bioavailability is 70% compared to the tablet, and as a result, the Cmax and Tmax are dependent on which formulation is chosen. It's very highly protein bound and is metabolized to tizoxanide very quickly, and as a result, nitazoxanide concentrations are negligible in the serum. Its half-life is 1.3 hours, and it is primarily excreted in the feces. Nitazoxanide is a relatively well-tolerated medication. The most common adverse reactions that are reported are abdominal pain or a general gastrointestinal intolerance, and this does appear to be dose-dependent, as well as headache, chromaturia, and nausea. And some post-marketing surveillance reports also reported out diarrhea, dizziness, dyspnea, rash, and urticaria. From a drug-drug interaction perspective, nitazoxanide is not metabolized by the cytochrome P450 system, so in general, these types of interactions should not be of concern. There is some caution regarding the use of nitazoxanide with other highly protein-bound agents that have a narrow therapeutic index, such as warfarin. However, there was one phase 1 pharmacokinetics study evaluating concomitant use of warfarin and nitazoxanide, and they found no difference in INR. However, this was only after one dose of warfarin was administered. When prescribing nitazoxanide, it's important to note that the tablets are not equivalent to the suspension because the tablet formulation is more bioavailable. Additionally, either product does need to be taken with food to increase the absorption of the product. As noted below, the area under the curve and the Cmax is significantly increased with tablet formulation. This is also noted with the suspension formulation, however, it's not as significant. And lastly, there's an extended release product at a dose of 300 milligrams that's being used in ongoing clinical trials that's also hopefully would allow for alleviation of some of the gastrointestinal side effects. The only current in vitro data available for nitazoxanide against COVID-19 was performed by Wang and colleagues. They measured cytotoxicity, virus yield, and infection rates of 9 different compounds using Vero E6 cells and evaluating this data at 48 hours. Some of the other compounds included in this study include remdesivir, chloroquine, and lopinavir-ritonavir. The authors did find that nitazoxanide did have in vitro activity against COVID-19 with a selectivity index of approximately 17. The authors found, unsurprisingly, that remdesivir outperformed nitazoxanide as well as chloroquine in regards to selectivity index. So of the 9 compounds studied, nitazoxanide ranked 3rd in regards to in vitro activity. After confirming nitazoxanide's in vitro activity against COVID-19, the next question that came up was, what is the appropriate dose of nitazoxanide to use for COVID-19? So this current study is a physiologically based pharmacokinetic analysis of 100 virtual patients that were all healthy to evaluate what the most appropriate dosing scheme would be. And here you'll note that the authors were aiming for an EC90 of 1.3 milligrams per liter, which may be confusing based on the previous EC50 from the last study. However, the other study was using micromolars. And using this physiologically based pharmacokinetic analysis, the authors found that there were only 3 dosing schemes currently available that would achieve an EC90 in both the lungs and the plasma. And then also taking into account gastrointestinal intolerance, the authors found that a dosing scheme of 700 milligrams every 6 hours or 900 milligrams every 8 hours was needed to achieve EC90 for COVID-19. The first trial that evaluated nitazoxanide for the use of COVID-19 was the SARITA-2 Trial. And this was a double-blind, placebo-controlled trial performed at 5 urgent care centers in 2 hospitals in Brazil. And it was primarily evaluating nitazoxanide in patients with mild to moderate COVID-19. Patients could be included in the study if they had one of 3 mild COVID-19 symptoms, such as fever, dry cough, and or fatigue, and it could be for 1 to 3 days of duration. They also had to be 18 years of age or older. They were excluded if they had any chronic and severe comorbidities, such as severe liver disease, chronic kidney disease requiring renal replacement therapy, severe heart failure, COPD class Gold 3 or 4, any cancer in the last 5 years, as well as any clinical suspicion for tuberculosis or bacterial pneumonia. And patients were assessed for inclusion based on a positive COVID-19 test, as well as the symptoms already described. And they were randomized to either nitazoxanide 500 milligrams every 8 hours for 5 days on a 1-to-1 ratio compared to placebo. And patients were given a thermometer and instructed to complete a self-administered questionnaire with lists of all of their symptoms and resolution. And they were instructed to return to clinic on the last day of therapy. In regards to demographics, the patients were primarily young at an age of 18 to 39, and primarily white patients were represented in the study. A very low portion of patients in this study had comorbidities, and 63 to 71% of patients had 3 days of symptoms prior to enrollment. Additionally, the mean oxygen saturation for both groups was 97%. The authors of this study found that nitazoxanide performed similarly to placebo in regards to resolution of patient symptoms at day 5 of therapy, with a p-value of 0.277. And this finding was consistent even when breaking down the composite outcome by symptom. So there was no difference in regards to resolution of dry cough, fever, or fatigue. In regards to secondary outcomes, the most notable secondary outcomes are the rates of PCR viral load and PCR positivity at the completion of therapy. So there was a significant reduction in viral load as well as rates of positivity between the two groups. With regards to inflammatory markers, there was no difference between the two groups or the rates of hospitalization after completion of therapy. Adverse events were similar between the two groups, with 30.9% in the nitazoxanide group experiencing adverse events and 30.4% experiencing them in the placebo group. The only notable difference between groups in regards to adverse events was that more patients in the nitazoxanide group reported abnormal color of urine. The authors of this study concluded that nitazoxanide did not affect symptom resolution after 5 days of therapy in ambulatory patients, but they did reduce viral load significantly with no serious adverse events reported. In regards to limitations of this study, I will note that there is a large degree of subjectivity in this study based on the symptom resolution form that patients had to complete throughout the duration of this trial. Additionally, the patients included in the study were intentionally meant to be healthy patients, and patients with extensive comorbidities were excluded from this study. And typically, patients with extensive comorbidities are the ones that have the severe complications from COVID-19. While the rates of PCR positivity and decrease of PCR viral load are of interest, it's unclear the clinical significance of this, as there was no difference of rates of hospitalization and symptom resolution, and any sort of transmission of COVID-19 was not recorded in this trial. However, the findings of this trial did appear to have some sort of influence on the style and design of the upcoming trial that I'll be discussing. Silva and colleagues performed a randomized placebo-controlled single-blinded pilot study evaluating nitazoxanide's role in viral load reduction in mild to moderate COVID-19. Patients were included in the trial if they had no more than 4 days of symptoms. Mild symptoms were defined as imaging suggestive of COVID-19 with oxygen saturations greater than or equal to 95% on room air and a respiratory rate less than 24 breaths per minute. Moderate symptoms were defined as oxygen saturations greater than or equal to 92% on nasal cannula and at a rate of less than 51 liters per minute, as well as the similar imaging findings required for mild COVID. Patients were randomized 2-to-1 to receive nitazoxanide 500 milligrams every 6 hours for 14 days versus standard of care. The original protocol of the study was to give patients nitazoxanide 1 gram every 8 hours, but after 2 patients took that dose and experienced extreme gastrointestinal intolerance, the dosing scheme was changed. The primary endpoint was to evaluate viral eradication of COVID-19 on day 7 of treatment, which was defined as a viral reduction of greater than or equal to 35%. I will be discussing the pre-interim analysis that has been released with 1/3 of patients enrolled in the study. Because this is a pre-term interim analysis, the enrollment rate in this trial was relatively low. There were 23 patients in the nitazoxanide arm and 13 patients in the placebo arm. The median age in the nitazoxanide arm was 44 years old and 53 years old in the placebo arm. Patients were primarily male in this trial, and about 3/4 of patients were hospitalized with mild disease and no need for oxygen therapy. And the oxygen saturation rates were similar between both patient arms. In regards to the primary outcome of patients achieving a viral load reduction greater than or equal to 35%, this was found to be statistically significant in favor of nitazoxanide. However, when evaluating the percentage of patients that had an undetectable viral load at day 7, this was not found to be statistically significant between the two groups. In regards to adverse events, 26% of patients in the nitazoxanide arm reported gastrointestinal events versus 15% in the placebo arm. And the authors noted that there was no difference in clinical outcomes, but did not discuss what the clinical outcomes were in this trial. The authors concluded that nitazoxanide outperformed placebo, and the number of patients with viral loads reduced by at least 35% in those with mild to moderate COVID-19, but had no effect on the rates of undetectable viral loads, and that further clinical outcomes were needed. When reading this study, I noted several limitations, one of which, and largely, is that this is a preprint article and trial and has not yet been peer reviewed. And I think because of that, some of the results were somewhat difficult to interpret. The percentage of patients achieving a viral load reduction greater than or equal to 35% was actually reported out in cycle thresholds as opposed to PCR values PCR viral loads. And as a result, could be difficult to someone reading for the first time and having to kind of understand cycle thresholds a little bit more. Essentially, the higher the cycle threshold is, the lower the viral load is. Additionally, the choice of using a viral load reduction greater than or equal to 35% wasn't necessarily explained what the clinical significance of that number was versus patients having like an undetectable viral load. And lastly, it would have been more helpful for the trial to actually report out what clinical outcomes were being evaluated. So that's something that we can at least be aware of the preprint results and know what to be looking out for the final results of this study. Nitazoxanide is currently being studied in 23 different clinical trials, the vast majority of which are active or recruiting, but there are some select studies with completed results that are pending. It's being studied in a variety of different ways, one of which is its use as monotherapy in COVID-19, but it's being studied with different severities of illness as well as at different dosing schemes. Additionally, it's being evaluated for use in combination therapy with other drugs that have in vitro activity against COVID-19. And then lastly, it's being evaluated for pre and post-exposure prophylaxis. I do want to highlight that Romark, the manufacturer of Nitazoxanide, did release a press release with preliminary results being reported out for its phase 3 clinical trial using Nitazoxanide 600 milligrams every 12 hours for 5 days. They were using the extended release product that's currently being studied, 300 milligram tablets. And this was evaluating patients that had mild to moderate COVID-19, and they were evaluating recovery time. They found no difference overall as the primary outcome, but they did have a predefined subgroup analysis of patients with mild disease, and they found that the time to recovery was about 3 days in the Nitazoxanide arm versus 13 in the placebo arm. And then they also noted that Nitazoxanide was associated with an 85% reduction in the progression to severe illness. So we look forward to seeing those results and discussing those as well. To summarize our discussion from today, Nitazoxanide is a relatively expensive agent that has antiviral and anti-inflammatory properties. Of interest, this agent is relatively expensive in the United States. However, in other countries where it's much more commonly used, it's extremely inexpensive and easy to access. And as a result, I think that is why this is being studied primarily in the countries where it's widely available. The current COVID-19 guidelines do not mention use of Nitazoxanide, so there's no recommendations for or against its use. Based on the available clinical data, it appears to lower viral load in patients that have mild COVID-19. However, at this point in time, it is of unclear clinical significance, and additional clinical data is needed to evaluate Nitazoxanide's role in treatment of COVID-19.